Good morning, everyone, and I thank the organizers for inviting me and the chairperson for their kind introduction. And I will thank Professor Pankaj sir for making my talk very easier as he has covered most of the topic and as a great teacher makes the path of the student easy. So it's become a lot easier. In this talk, some slides may appear to be daunting, but you need to pick up the key concepts or the key themes. You do not need to understand all the aspect. And I'll try to avoid CAR-T as much as possible because you have another 2, 3 talks scheduled on that. Of course, CAR-T is something that I do routinely, but for this talk, I'll try to avoid. So, in a simple way, what is gene therapy? So, in a simple way, you deliver the genes, and which could be DNA, RNA, mRNA, etc., to repair the damaged genes which is causing the disease. This is a very simple definition. So coming to the history, specifically how it has evolved. So in the 1980s era, there was scientists proved that we can actually deliver the genes through lentivirus, adenovirus, etc. But at that time, the technology was not safe, and cases of cancers were reported where these viruses transformed and caused cancer to the patient. So that was one of the drawbacks with the technology at that time. Subsequently, it was more refined and safer viruses and other vectors were used. And in 2000, CAR-T prototype was developed, and it will be interesting to know that the first CAR-T was used in ovarian cancer, which is a solid tumor, not in hematological malignancies, where it is now routinely used. So of course it failed because it was a first generation CAR-T and subsequently it was modified to improve the efficacy. By 2010, CRISPR was developed, which was a game changer as far as gene editing technology was developed. And by 2020, in the current era, we have improved base editing technologies, and in vivo CAR-T were also developed. And most important thing was the integration of AI and bioinformatics. So, in possibly we will have a more synchronized collaboration of bioinformatics, AI, microbiome, and all the immune cells, etc. So it will be more of a hologenic therapy, which will also include all the microbiome. So this is how the field is developing. In a simple way, you can do in vivo gene editing, which sir had showed, and you can and the classical example is for the hemoglobinopathies, and you can also do gene editing outside the body, that you take the cells and do CAR-T, etc. We have two choices. We can do a gene addition, and the other concept is targeted genome editing. In gene addition, you take lentiviruses, and nowadays you have liposomal nanoparticles and different other particles. So, without even taking a viral vector, you can incorporate the genes. So, this form is called gene addition. So it has been shown to be successful in clinics, and it also has been shown to be long lasting, but it does not transform the gene completely. Whereas if you do a gene editing by using different nucleases and different tools, so you are able to change the damaged gene completely, and it is also long lasting therapy. So in cancer we have different gene therapies strategies, and this is I will say some examples, not a comprehensive list. So you can have suicide gene therapy, tumor suppression gene activation, inhibition of oncogene activation. I'll just give you small examples for all these strategies. So example in gene silencing. So if you read melanoma and leukemia, you will see that c-MYC has some role in tumor aggressiveness and increasing the tumor survival. For example, in DLBCL, Burkitt. So what you can do, you can take small non-coding RNA sequences. They will bind to this c-MYC, and it will inhibit the c-MYC, and this c-MYC will be inactivated. Now, since c-MYC is inactivated, the tumors will become less aggressive and there will be increased survival of the patient. Now, right now, we do not have a well-established CMYC inhibitor as far as targeted therapy or a conventional therapy is concerned. So, by using gene silencing, we can target such type of gene alterations for which right now we do not have effective drugs. Another is the gene defect correction. You know, P53 is one of the most common mutations in most of the cancer, and usually in solid tumors, if there is a P53 mutation, the outcomes are bad, and same thing applies to hematological malignancies also in general. So in non-small lung cancer, if there is a P53 mutation, then these are more resistant to conventional chemotherapy. So you can, through gene technology, you can put a wild type P53 and that will cause the apoptosis of the malignant cell. And there was a gene desin adenovirus which was developed in China. It got approval by the Chinese regulatory agencies for head and neck cancer. Of course, by that time the immunotherapy evolved, that is the pembrolizumab, nivolumab. So it did not gain that popularity, but it proved that this type of approach can be used. And P53 is one of the very difficult genes which can be targeted right now. A lot of trials are going, but science has met with failures more rather than success. Another example is suicide gene. So, for example, prostate cancer and glioma, they have this thymidine kinase. So, herpes simplex virus thymidine kinase is inserted there. And once that enzyme is inserted, all of you know from your pharmacology that it activates the ganciclovir prodrug to its active form ganciclovir triphosphate. Now, since the enzyme is present only in the tumor cells, so only the tumor cells are killed. So this is another example. Coming to the anti-angiogenic therapy, we know that hepatocellular carcinoma, renal cell cancers, and even glioblastomas. Here the VGF and angiogenesis is one of the key drivers of the mutation. And hence, if you see multi-targeted tyrosine kinase inhibitors such as lenvatinib, sorafenib, sunitinib, they are effective in these type of tumors. So same thing we can do by this gene therapy also. So endostatin is one of the inhibitors of the gene angiogenic pathway. So through gene therapy, you can induce this gene and it will inhibit the angiogenesis and leading to apoptosis of the cells. And of course, the technologies can be CRISPR or other technologies. So all these examples are fascinating, but there have been certain challenges, and one of the key clinical challenges have been the delivery, and the response rates have been modest, and there are various factors. One of the key factors is that solid tumors are very complex. They have got a very high antigen heterogeneity. There are different clones of the tumor, and then the tumor mesenchymal cells are also there, which has inhibitory effects on whatever therapy we plan. So results have been modest, but of course the technologies have been improving, which I will come in subsequent slide. The delivery strategies sir has already covered, so I will skip this slide. Coming to the gene editing tools, sir has taught all these points, but a few points I will add. The earliest was a meganuclease. It was a large enzyme which will cover a large portion of the DNA. But the problem was that it was very difficult to use for a different sequence of DNA. So that was one of the challenges. So it was a basically, you can think it of as a highly specific lock and key. So the key can be used only for one lock. If you want to make it for a different lock, it is very challenging. So it was not very much used in clinical practices. Then come the zinc finger nucleases and the talents. So in these two technologies, there were nuclease domains, and protein was used as a binding agent between the DNA strands and these enzymes. Now, we have to, every time if we want to use these enzymes, we have to make a very specific protein which will bind to the DNA as well as the enzyme. So it was technically very challenging, and So these were not very popular. Talent is still used in some of the CAR T cell products, and some of the pharmacological companies still use it. And CRISPR is the easiest because you only need to design the complementary RNA, which is called single guided RNA, and it will attach the track RNA with the enzyme, and you can degrade the DNA. So with whatever method, once you achieve the double strand breaks, so you have non-homologous end joining and the homology directed repair. The non-homologous pathway, it is not very accurate, but it is very efficient. So whenever it repairs, there will be insertions and deletions. So this is most commonly used in knockouts. You want to damage the gene permanently, you can use this non-homology. It is efficient, it is easy, but of course the joining will not be perfect. Homology directed repair, it is very perfect. It will repair it accurately with fidelity. So it is most commonly used in knock-in, where you want to insert a gene, there it is used. Limitations is one of the key limitation is off-target effect. CRISPR is very sensitive and specific, but despite that, sometimes CRISPR enzyme, they targets other parts of the genome. The reason being that it's something like that. Some of our close friends, if even if they wear masks, we are able to recognize. But some persons whom we meet, whom we do not meet often, if they wear masks, we might get confused. So CRISPR is like that. It is sensitive, but not yet very sensitive. Sometimes it happens that there are opened chromatin region of the genome, and CRISPR finds it easy. Okay, this part is open, where it can bind. So these issues are there. So there can be off-target effect. Of course, there are ethical and safety issues. And again, it has been found that when you use CRISPR, these cells are in hyperactive states, and they have an increased tendency for immune reaction. They have a heightened sensitivity. So these are some of the challenge. Of course, the cost and technological access. In fact, many times it happens that the company or the group who develop these technologies, if you see the glioblastoma trial, if you go through the list of phase 1, you will find 3-4 therapies which have shown very encouraging results in phase 1, but they never went into phase 2 because the group or the company, they went bankrupt, whoever developed that. So these are other issues with this therapy. So in CRISPR in cancer, so as we can repair the disrupted oncogenes. So there is an oncogene causing abnormal cell proliferation. By using CRISPR, you do the double strand breaks, and then you knock out these oncogenes, and as a result, apoptosis starts to occur. And similarly, in the reverse way, we can also promote the tumor suppressor genes. Another thing is that whenever we treat cancers, there are some things happen, which is the multi-drug gene resistance starts to appearing. So, say we have started to treat a patient, and it has developed multi-drug resistance. Say it has got a very high function of P-glycoprotein, which is responsible for MDR. So we can knock out that with the help of CRISPR technology. Say in a lung cancer patient, you are treating, and that patient develops T790M mutation, and you know once this mutation develops, then our cheaper TKIs, Jeftinib or Erlotinib, they won't work. So what you can do, you can take help of these technologies. You can change the polymorphism of EGFR T790M and make the tumor again resensitive to your first generation TKIs. So, and apart from that, suppose you have a CAR T cell, and one of the issues with CAR T is the exhaustion. So by exhaustion, you mean that if the CAR T cells are persistently stimulated by the tumor cell, they get fatigued and they are not able to kill the tumor cells efficiently. So it is mediated through some of the pathways like PD1 and LAG3. So through these gene editing technologies, you can disrupt or disable these pathways. So what will happen? Your CAR T cells will not get exhausted. It's like giving glucose to a runner. So that's why you can think of it. So there are a lot of CRISPR trials going on. For example, T cell lymphoma, they have used the knockout for B2M and track, and they have found very good response rate of almost 50% with one-fifth of the patient achieving CR. And a lot of these trials are going on sarcoma, myeloma. So you can target tumors across the whole oncology spectrum. And you can also use these technologies in your lab. So, for example, you have developed a cancer cell line, which is routinely done in most of the Indian universities, and you damage the cells using CRISPR, and then you give drugs to kill the cells in that cell model. Now you pick up the surviving cells, you analyze them, so you will know which mutations are basically responsible for drug resistance. So you can use these tools to study cancer cells in your lab as well. And for you can also develop tumor xenografts. So you can take a mice and take cells which are damaged by CRISPR, and basically you inhibit or promote oncogenesis. This will lead to tumor formation in the mice, and then you can study the mice model. Again, in GVHT also, there are a lot of interactions of the cytotoxic T cells with host cell, which causes GVHT. And you have these cells also act against the cancer cells, due to which you get the graft versus leukemia effect. So one question arises, can we decouple them? Can we have an ideal situation where the graft will eliminate only leukemia cells, it will not cause GVHT? So there are certain pathways which you can edit through these methods. Coming to the cell therapy, so there are a lot of cell therapies being developed. One is the CAR T cells, NK cells, tumor infiltrating lymphocytes. Now, CAR T cells, they can cause CRS, they can cause ICANS. Again, there is an antigen escape where you give CAR T, the tumor evolves itself, and there is an antigen escape. In solid tumors, as I told you, that there is tumor heterogeneity. So one clone will express one set of antigens, the another clone will express another set of antigens. So you can modify the CAR T. Say you want I want both the clones to be targeted. So you can design your CAR T in this way that it will identify those clones where either of the cells antigens are present. Or you can also design in such a way that either of them are present, and an antigen, if it is present in a normal cell, it gets inhibited. So there are various logics you can apply and not, or I'm not going into detail, but these things can be done in cell-based therapy. You can also design CAR T cells that when it gets activated, it will release cytokines, and which will improve the efficacy of CAR T cells. Or you can also design that it will release bispecific antibodies. NK cells have an issue with persistence. So you design a NK CAR T and you give it to the patient. So you will find that it will not stay in the body long. So you can do knockout of TGF genes, which will increase the persistence. Another way is that you can incorporate IL-12 cytokine, which increase its memory. So these are ways which you can modulate, and you can overcome the limits of conventional cell-based therapy by using these technologies. For tumor infiltrating lymphocytes, the tumor environment is very hostile to these tumor infiltrating lymphocytes. In fact, it has been shown in metastatic cancers that at metastatic sites, they don't allow these normal lymphocytes to enter the tumor environment. So you can design interleukin antibodies which will permit and increase the ability of these cells to go into the solid tumors and thus make it more effective. The other cells that are emerging is the T cell receptor therapy. This is different from CAR T. Here we don't do a chimera, we just modify the T cell receptor. Our dendritic cells are being made, and we also have technologies where we can modify the mesenchymal cells. So, for example, exosomes, etc., are being studied in GVHT. You can modify exosome production so that you can have more exosomes with the active components. And we can also have use this technology. So you have inducible pluripotent stem cells which can basically evolve into any type of cell line, and you can have off-shelf therapies that you do the gene editing, that pluripotent cells will become CAR T or CAR NK, whatever you want, and then you can use it as option. So again, we have trials going on for CAR T, solid tumors also, prostate cancer, glioblastoma, lung cancer, these are being studied for TILs. Melanoma is the prototype, and lung cancer. Again, NK cells also are used in AML, so these are being used. T cell receptor therapy has been approved in sarcoma. So the toxicities of TIL are capillary leak syndrome, CRS, ICANS, hypophosphatemia, fever, diarrhea. CAR-T in solid tumor also they can cause CRS, ICANS, hepatotoxicity. T-cell receptor therapy they can cause ARDS, pulmonary hemorrhage, uveitis. So these toxicities we need to be aware of. The next approach is that can we combine two forms of therapy. So we have a cell therapy and it can be combined with any another therapy. So we have we can combine therapy with immunotherapy. So we'll give cell therapy and we'll also give immunotherapy. Or it can be combined with radiotherapy, chemotherapy, vaccines, cytokines. So the basic premise, I'm not going to in depth to this. The basic premise is whatever agent we are combining, it acts on other pathway which increases the potency of the cell therapy. So, for example, if you give, say, pembrolizumab or nivolumab with CAR-T, so pembrolizumab, nivolumab will block the PD-L1 pathway, and the CAR-T will act on the pathway CD19 or HER2, whatever way it has been designed. So you are getting benefit of dual agents. So if you give radiation therapy, when cell degeneration occurs, there are molecules called DAMPs. They increase the cell efficiency. So this the rationale is same. So for example, ibrutinib, acalabrutinib, they increase the persistence of CAR T cells. So you can combine them with other forms of cancer therapy. And we have some promising results from early trial. For example, in mesothelioma, you know that relapse refractory mesothelioma, we have very bad outcomes. So if you take a CAR T which targets mesothelin combined with pembrolizumab, we have 1 year overall survival of almost 83%, and 2 patients out of these 23 had attained a CR. And you know how difficult it is to achieve CR in mesothelioma. In TILs, they have been combined with pembrolizumab, and we have got a very good response rate of almost 50%. And patients had also attained CR. And this data is of relapse refractory patients. Dual CAR T also has shown very good results. And if you combine cell therapy with radiotherapy, that is GPC3 CAR T with glioma, so 5 year disease-free survival was 100%. So we have got very encouraging results with this combination. So this is another aspect where the science is evolving. So I conclude here. Any questions I will be happy to take.